Hi, I'm Aya Kamaya, and I will be presenting to you the SRU Gallbladder Polyp Consensus Committee Guidelines. So before I present to you the guidelines, I want you to look at this ultrasound of a gallbladder with a polyp that's 7 millimeters in size, and it has this ball on the wall configuration. And I want you to think to yourself, what would be your recommendation for this patient? So this year, the SRU convened a consensus committee to tackle the issue of gallbladder polyps, and we are providing recommendations for incidentally detected gallbladder polyps seen on ultrasound. We do acknowledge that as evidence accumulates, our recommendations may potentially change in the future. These are the members of the SRU Gallbladder Polyp Consensus Committee, comprised of radiologists, surgeons, gastroenterologists, pathologists, and a sonographer who are all experts in gallbladder and hepatobiliary pathology. So just a little bit of background about gallbladder polyps to help put this all into context. So the vast majority of gallbladder polyps are benign, most commonly benign cholesterol polyps. These are usually between 4 to 8 millimeters in size. Only a small minority of gallbladder polyps are what we term neoplastic. These are intracholecystic papillary neoplasms, also known as adenomatous polyps. And on average, these are between 18 to 21 millimeters, so a little bit larger in size. And it's actually unclear what is the natural course of ICPNs. The pathway towards carcinoma is unclear and actually controversial. Only 6% of gallbladder cancers, okay, gallbladder cancers are very rare. And of those rare cancers, only 6% are associated with ICPNs. That means 94% of gallbladder cancers do not arise from a polyp. A recent study from 2020 in JAMA by Zakowski et al. Looked at all of Northern California Kaisers, and they found that the rate of gallbladder cancer was the same in those with and without gallbladder polyps. The 10 millimeter threshold that we commonly use for surgical recommendation is also controversial, and recent studies have found that if you use that threshold, that leads to significant overtreatment of gallbladder polyps. You also want to balance the morbidity and mortality of cholecystectomy compared to the risk of malignancy, which is very low at 0.4% for a gallbladder polyp that measures 10 millimeters or greater. So before you use the SRU algorithm, we want you to go through this flow chart to determine whether the SRU algorithm is for the gallbladder polyp in question. If the ultrasound is technically inadequate, we recommend a short interval follow-up ultrasound within 1 to 2 months. If you can't tell if you're looking at a polyp versus tumefactive sludge or adenomyomatosis that measures over 10 millimeters, you could either do a short interval follow-up or a contrast-enhanced ultrasound or MRI for further characterization. If you think you're looking at an invasive cancer or malignancy, then refer to an oncologic specialist. If there's a history of primary sclerosing cholangitis, refer to GI specialty guidelines. Otherwise, you can use the SRU algorithm, which I will present to you next. So we define extremely low risk as a gallbladder polyp that has a ball on the wall configuration. That means that it looks like a ball that's sitting on a flat surface, resting on a flat surface, or a pedunculated polyp that has a very thin stalk. If you have an extremely low risk polyp, then we use a size threshold of 9 millimeters. 9 millimeters or less, no follow-up is recommended. If the polyp measures between 10 to 14 millimeters, then we recommend follow-up at 6 months, 12 months, and 24 months. Now we're looking for growth. And on the follow-ups, if there is growth of 4 millimeters or greater within 12 months or less, then we would recommend a surgical consult. If on the follow-ups, the polyp exceeds 15 millimeters in size, then we also recommend a surgical consult. We define low-risk polyps as either a pedunculated polyp with a thick or broad stalk or a sessile configuration. Also, we can take into consideration patient factors such as ethnicity, North Indian, North or South American indigenous. And for these low-risk polyps, We use a different threshold, 6 millimeters or less, no follow-up, 7 to 9 millimeters, one follow-up at 12 months, 10 to 14 millimeters follow-up at 6, 12, 24, and 36 months, or a surgical consult. And then at 15 millimeters, we would recommend a surgical consult. We define indeterminate risk as a polyp of any size with adjacent focal wall thickening greater than 4 millimeters in thickness. And that wall thickening cannot be attributable to edema, a mucosal fold, adenomyomatosis, or a contracted state. If you have an indeterminate risk polyp, then we use a threshold of 6 millimeters or less, where we would recommend a follow-up ultrasound in 6, 12, 24, and 36 months, or a surgical consult. Or if it measures 7 millimeters or greater and has that thick wall, focal thick wall, then a surgical consult. If you're not sure which algorithm to use, we recommend using the low risk algorithm. And then this is everything I just said in chart format in one easy to reference page. So going back to our 7 millimeter ball on the wall polyp, what is your recommendation? Well, with the new SRU guidelines, we would recommend no follow-up. So thank you so much for your attention.